own tumor master, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. Today, we bring attention to a condition that often goes unnoticed until it significantly impacts the quality of life of a patient. Nothing else than multiple myeloma, which is a silent blood cancer. Early symptoms are frequently vague and easily overlooked, leading to delays in diagnosis, especially in our setting. Today, we will understand the red flags, the evolving treatment landscape, and the challenges that patients face. It is a privilege to welcome Dr. Krishnamani, a highly respected leader in the field of oncology. For over a decade at AOI hospitals in Hyderabad, he has been at the forefront of cancer care, bringing deep expertise in the management of solid tumors and hematological malignancies and oncological emergencies. What truly distinguishes him, however, is his compassionate, patient first philosophy. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. Today we have chosen myeloma as our topic, or as it is called as multiple myeloma. So we'll talk a little bit of what myeloma is. We'll try to bust a few myths, what the symptoms are, how should the general public be aware, and what are the new things happening in the field or in the landscape of myeloma.
Sir, can you begin by telling us what is this disease, what it actually affects, or how is the pathology of this disease happening?
So multiple myeloma is a kind of a blood-related disorder where there is a cell called plasma cell. These plasma cells grow abundantly. So it's a disorder of plasma cells where the plasma cells go and affect multiple organs like the bone, like the bone marrow, like the kidney, sometimes the heart, the nerves, all these kind of things. So it's a plasma cell disorder. It is a clonal disorder. Clonal means one single cell line is affected. So it's a clonal plasma cell disorder with kidney, neurologic, bone, and hematological involvement.
So, what can you tell us about the epidemiology of this disease?
Myeloma is generally a disease of the elderly. Is usually myeloma you see in ages above 65 or 70. If you see myeloma in young, they tend to be aggressive. There is a variant or there is a type in myeloma which is called a plasma cell leukemia, which is myeloma spilling over into the blood, where a lot of plasma cells are seen in the blood. That's seen in young usually, and it is very aggressive. Myeloma is common in the in common in Australia, common in countries like New Zealand, in southern parts of North America, in certain parts of UK, etc. Men tend to be more involved, more likely to be affected than women. And it seems to be more aggressive in black people compared to the white people. So overall, a disease of the elderly men. And though there are certain pockets in the world where myeloma is commonly seen, in India also it's extremely common. In fact, in India, we also tend to see a lot of young people with myeloma. Young means below 60. Uh, and they come with a different kind of presentations.
Sir, which leads me to my next question. Like, why do they say multiple myeloma is a silent cancer? What are the silent signs or symptoms which the patients usually overlook?
See, I'll tell you some of the signs. You can come with fatigue. You can come with weakness. You can come with loss of appetite. You can come with exertional breathlessness. All this is due to anemia. Somebody can come with uh, decreased appetite, breathing difficulty, swelling of the body, which is called anasarca, or swelling of the lower limbs. They check with the doctor, their creatinine is on the higher side. So kidney failure is causing these kind of symptoms. Because of kidney failure, there is waterlogging in the lungs, you get breathless, there is waterlogging in the legs, which we call edema, there is waterlogging in the whole body. Why kidney failure? Because myeloma is affecting the kidney. So you come with either anemia related symptoms or kidney related symptoms. Sometimes patients come with bone pains, elderly people with fractures, severe bone pains, swelling over the skull or swelling over certain other bones. Sometimes patients can come with confusion. They can come with seizures, fits. You check them, you do MRIs that this things would be normal. Serum calcium is extremely high. Hypercalcemia due to myeloma. So myeloma can present. Now let me sum up everything. You come in breathlessness, loss of appetite, loss of weight, bone pain, seizures, headache. You can come with no symptoms. You can just be detected. You can come with renal failure, breathing difficulty. So everything can present like mimic myeloma. So myeloma doesn't have one specific symptom. What you should understand is it can cause what we call CRAB, crab. C for calcium, R for renal, kidney, A for anemia, B for bone. When you talk about calcium, immediately you should worry about all the high calcium symptoms. Renal failure means kidney failure. Anemia means all anemia. Bone means bone pains, fractures. Then you will understand. Beyond this, you can also have heart involvement. You can come with, what do you say, bleeding. If the myeloma is very severe, the platelets are very down. You can come with infections, very important infections. Myeloma patients are extremely prone to infections. They can come with bleeding. They can come with neuropathy. So it is a silent killer. Why? Because you don't have one specific symptom. You need a good workup.
So, can you explain about the diagnostic workup for this patient?
So, see, basic, when you come with these kind of symptoms, your doctor is going to do a complete blood picture, a kidney function test, a liver function test. In your complete blood picture, you may have anemia. WBC platelet may be low or normal. ESR is usually, they do an ESR also. Then you do a liver function test where the albumin is very low. We say AG reversal, albumin globulin reversal. Generally, albumin should be high, globulin is low. Here it is ulta. Creatinine may go up, calcium may go up. That's in your kidney function test. Then you get an idea. Okay, AG reversal itself means you're probably dealing with myeloma. Okay, and then what ESR is high. And then what you do is you start working up. In your workup, there are three things. One I told you is crab. Then one is a bone marrow. You will do a bone marrow to look for plasma cells. If you have more than 10% plasma cells on the bone marrow, then you have myeloma. You have crab symptoms. Then you also do something called electrophoresis or immunofixation. This is done on the blood. You will see an M spike, myeloma spike. M protein, we say. M protein means this protein is in very high quantity in your blood. That is because of the plasma cells or because of the disease. That is causing all these problems. That is seen as an M protein in the blood, that is serum, and in the urine. And the urine, it is called Benz-Jones protein. In the urine, it is called Benz-Jones protein. And finally, to add, you will do certain simple tests called LDH, which will be raised. Beta 2 microglobulin will be raised. And in that M spike, you say M protein is there. That protein contains a light chain and a heavy chain. So there are the light chain, you look for kappa and lambda, we say. That is called serum free light chain assay. Serum free light. So you look for the M protein and SFLC. In the SFLC, it should be either kappa or lambda. It cannot be both because it is monoclonal. And last but not the least, you will do a complete skeletal survey. You will do MRIs or you will do PET-CT or you will do X-rays from head to toe to look for bony lesions. So CBC, RFT, LFT to look for anemia and other cytopenias, kidney failure is creatinine is high, calcium is high on renal function, liver function, albumin, AG reversal is there. Then you go for LDH, ESR, beta 2 microglobulin, which will be raised. Bone marrow, more than 10% plasma cells, electrophoresis and immunofixation on blood and urine. You will see an M spike. Then you will do serum free light chain assay to see which light chain component is more, kappa or lambda. You look at the ratio kappa by lambda, and finally you will do a skeletal survey, X-rays or CT scans or PET scans from top to down. This is how you categorize or you diagnose myeloma.
So, usually the patients are diagnosed at which stage of the disease?
In myeloma, technically or medically, I will say a stage 1, 2, 3 based on certain genetic factors or LDH. But for a patient, myeloma means bone marrow is positive, M spike is there, and CRAB criteria are there. If you don't have CRAB criteria, if you don't have plasma cells, you have only M spike. It is called MGUS, monoclonal gammopathy. Monoclonal gammopathy means that spike of unknown significance. You don't know the significance because bone marrow is normal, because no symptoms. Now, if you have bone marrow positive and M spike, but no symptoms, that is called smoldering myeloma. Smoldering means it is silent without symptoms. So, MGUS has only M spike. Smoldering myeloma has M spike plus bone marrow involvement, no symptoms. Myeloma has symptoms also. So, you will always present in the myeloma stage. But if you have certain abnormalities, if the doctor picks up early, you are picked up at MGUS or smoldering also. In myeloma, you will divide in stage 1, 2, 3. 1 means normal LDH albumin. 3 means on the bone marrow, you do something called FISH to look for certain genetic abnormalities. If you had some bad cytogenetics like P53, 414, we say, then you are stage 3. Between stage 1 and stage 3, all patients are put in stage 2. That is for classification. Why? Because stage 1 patients can live beyond 6 years. Stage 2, stage 3 patients, we say survival is 3 to 4 years. That is more prognostic classification. But otherwise, for a common man, stage means he presents in myeloma, he presents with symptoms.
Is there any genetic testing which is done for these
Yeah.
patients?
You do FISH testing to look for P53 abnormalities, hyperdiploidy, we say 414. So there are some bad risk cytogenetics, as I told you, some good risk cytogenetics. That is how you stratify them.
Sir, can you tell us about the treatment?
So, treatment for myeloma, please understand, surgery is not a part of your treatment. Treatment is mostly systemic therapy. Systemic means treatment given all over the body through blood. One, you can have chemotherapy like drugs like cyclophosphamide or melphalan. Newer drugs, proteasome inhibitors like bortezomib, carfilzomib. Then immunomodulatory drugs like thalidomide, lenalidomide, pomalidomide tablets. Then MABs, monoclonal antibodies like daratumumab, ixazosib, CAR T cell therapy, and finally autologous transplant. So in myeloma, you will divide the treatment into, is somebody less than 70 years fit for a autologous transplant, or somebody is more than 70 years or unfit for a transplant. If you are elderly, unfit for transplant, you are given these drugs. Generally, we give cyclophosphamide, bortezomib, or dexa steroids, or when we give bortezomib, lenalidomide, dexa, double drug, triple drug. So this is a very long topic, very scientific, too much of data. I will not go into it. For a common man, if you are old, transplant not eligible, you are put on chemotherapy and other drugs, either two drugs, double drug, or triple drug. And after 4 months or 3 months, all the scans are done. Your M spike is done. If M spike comes down, serum free light chain comes down, creatinine, everything settles, bone marrow comes down. That means you have reached some response, partial response, or complete response, or very good partial response. After that, you are put on maintenance treatment. It is a never ending thing, chronic thing, but you will do well. If you are a young transplant eligible guy, after 3 to 4 months of therapy, usually with 4 drugs, we take up for transplant. Transplant is an autologous transplant. The patient's own cells are harvested and given back. The hospital stays usually 15-20 days. Transplant gives long-term remission, and after transplant, they are put on maintenance for 2 years. And after that, they are on regular follow-up to look for recurrence. So transplant eligible or transplant ineligible, and prior to transplant, you give drugs to reduce the disease. It could be two doublet. Generally, nowadays we use either triple drugs or quadruple drugs. If you relapse, the drugs which were not used earlier are used now. That is the way you have to go ahead.
So, what would be the percentage of patients who are transplant eligible and transplant ineligible in our Indian setting?
So in the Indian setting, it is not like that. Is what we should consider is most of the young patients we should aim for a transplant if their health permits. If their kidney function, liver function, heart function, pulmonary function is all okay. All young below 70 or 65 fit. 65 you can take as a cutoff. Fit age is not the only cutoff. Remember that you can be 68, but you can be super fit. You can be 50, 55, chronic smoker, your lung is gone, alcoholic, your liver is gone, you have hepatitis or HIV, then you are not probably going to be a transplant candidate. So, fit guy, 65, sometimes even you could stretch up to 70 maybe, but India, I think 65 is okay. You should aim for a transplant in all patients.
Sir, patients who undergo this autologous transplant, do they also have a chance of getting the disease back?
Yes, anybody can get the disease back. Transplant allows you to be in remission for a longer period of time, also cures in a few in a subset of patients. So that is the advantage of transplant. Longer remission, deeper remission, and possible cure.
So, what are the newer therapies which are available for multiple myeloma patients?
So the proteasome inhibitors, which is called bortezomib, the immunomodulatory agents, lenalidomide, the monoclonal antibodies, daratumumab, and ixazosib, CAR T cell therapy. All these are the newer therapies available for us to treat myeloma.
Sir, can you highlight a little bit about the financial burden that these patients face?
So when you go for chemotherapy every week for a month, treatment should not cross beyond 20,000, beyond 15 to 20,000. Bortezomib, lenalidomide, dexamethasone. So 15 to 20,000 into 4 months. When you go for a transplant in a good center with good infection precautions, with proper safety, you can do an autologous transplant anywhere between 5 to 8 lakhs today. And they are covered under insurance. There are agencies willing to help patients, and that should be done. It's not expensive.
Sir, what can you tell us about the prognosis of this disease?
So myeloma now has become a chronic disease. Patients with myeloma who do transplants, we have patients who are doing well for the last 15 years or 12 years, 13 years. Those who don't undergo transplant, 4 years and 5 years and beyond. So it's a chronic disease. You need some form of therapy. You need maintenance therapy. So the prognosis is good. You should be worried about falls in the elderly because their bones are brittle and weak. You need bone injections. By bone injections, I mean bone strengthening injections like zoledronic acid or denosumab. Infections are very common, so you need medications as prophylaxis for infections, for fungal, bacterial, viral infections. So the prognosis is good, but watch out for falls, watch out for infections, watch out, you need some blood transfusions in between, watch out for relapses and those kind of things.
Sir, how would you describe the quality of life of these patients?
Patients who are on treatment do well. Patients during transplant, those 10 days, they have a bit of trouble. After that, post-transplant, they're perfectly fine. Now we have a patient who's a professor who sits in the northern part of the country. And even today, he messaged me saying that he's able to discharge his duties perfectly well after transplant. And the injections are taken at the local place. He's able to work. He doesn't even look like a patient. So the quality of life is excellent.
Sir, what message would you like to give our viewers of the summary of today's session?
So be aware of myeloma. It can present with a variety of simple symptoms. It's a blood related thing, but it affects multiple organs. Chemotherapy, or rather than chemo, I would say newer medicines like immunomodulatory drugs, etc., proteasome inhibitors are all the treatments. If you're young, you should be eligible for an autologous transplant. It's not that expensive. It will really work out for you. And these patients do well.
Sir, what can you tell us about the second opinion campaign which is being run by you?
So we are running a second opinion campaign to help cancer patients. If you have any reports, you can WhatsApp us. We'll reply back to you with the limited information we have so that we can guide you better. And then you can contact your doctor there and go ahead.
Thank you for enlightening us on this session, and we hope to see you again next Friday with another interesting topic, sir. Thank
Thank,
you for your time, sir.
thank you.